Okay, aplastic anemia. So I used the analogy before of the bone marrow. What was the analogy? What is the bone marrow? What's the comparison that I use for the bone marrow? What is it? What did I call it?
Factory?
Yeah, it's the factory because it's where you make your red blood cells, white blood cells, platelets. It's where you make your cells. Okay. The thing about aplastic anemia, that's where I say with aplastic anemia, the factory is shut down. Nothing is happening. Okay. You don't get any cells produced, no reds, whites, or platelets. Okay. So, and that's not a good thing. Aplastic anemia is not a good thing. So, aplastic anemia refers to pancytopenia, pan meaning everything, all, and it's associated with a hypocellularity of the bone marrow. Hypocellularity, that means that there's not too much cellularity. There's a lot of, as opposed to hyperplasia. If you have hyperplasia, you have a lot of marrow material that's actually working. In aplastic anemia, it's hypocellular, so it doesn't have too many cells because, like I said, in comparison, the factory is shut down. It's hypocellular, not very much bone marrow activity. So there's a severe reduction in the amount of hematopoietic tissue, and as a result, you have deficient production of blood cells. Okay, so this is a normal bone marrow. You see all these sinuses there? That's fat. Okay, those are fat. That's normal to have but all the other cells are either erythroid or myeloid in nature, or even I want to see. I didn't see any platelets or nursing cells, but this is a normal marrow. Okay, so this marrow space, but then you have erythroid and myeloid precursors there. In aplastic anemia, look at all the space there. There's not too much erythroid or myeloid cells present. There's a lot of white space or empty space there. So that's the hypocellular activity of the bone marrow. So this is what bone marrow looks like for aplastic anemia. It's very hypocellular. Okay, so there's two types of aplastic anemia. One of them is acquired and the other one is congenital. Acquired accounts for over 95% of the aplastic anemias. And the other one, greater than 5%, is a congenital one. I'll talk about that last. The acquired ones are either primary or secondary. Primary meaning idiopathic or unknown cause. Your bone marrow shut down, but the doctor doesn't know why. Okay, it's idiopathic or he doesn't know why. You have a normal life, you're not exposed to anything, so you're not doing anything out of the ordinary. All of a sudden, your bone marrow decides not to make any more cells. So that's idiopathic aplastic anemia. The other one, secondary aplastic anemia, is caused by various reasons like chemical agents, exposure to chemical agents, drugs, ionizing radiation, infection, and other miscellaneous causes. So that'll be the majority of my lecture. So primary, secondary for the acquired, and congenital for the congenital. I mean, 5% the congenital. Okay, chemical agents that cause aplastic anemia. So benzene, trinitrotoluene, arsenic, insecticides, and weed killers. So a lot of these agents have the benzene ring, and that's actually the source of the aplastic anemia, like trinitrotoluene and benzene. So it's modification of the benzene ring with a nitro or nitroso group that actually has been linked to the aplastic anemia. So the benzene ring, okay? And benzene is found in many industrial agents like solvents, cleaning agents, fats, alkaloids, manufacturers of drugs, dyes, and explosive like TNT, that's an explosive. And the way you acquire the benzene into your system is that because benzene is volatile, you can breathe it in by inhalation. Okay, that's how you expose yourself to the benzene, and as a result, you can get aplastic anemia. Drugs, patients can have unpredictable reaction to drugs. And what they can do is when they're exposed to certain drugs like chloramphenicol or an anti-inflammatory drug like phenylbutazone, you develop antibody. You can develop antibodies, and it's the antibody that against these certain drugs that you develop. So this would be another example of an alloantibody, right? External exposure, I just talked about in the last lecture. So it's an external exposure to an antigen, and the antigen here would be the drug. And you develop an antibody, that's your reaction. So therefore, these are alloantibodies against drugs. And what happens is that these antibodies will cross-react with the bone marrow cells and tell it to shut down. Okay, that's what happens. So drug-induced hypoplasia. So the bone marrow now becomes hypoplastic, you know, but it's reversible. And the way you reverse this type of aplastic anemia is just to remove the drug, take away the chloramphenicol or take away the phenylbutazone, and then you'll stop the antibody development. So it's fully reversible. So that's a good sign. Ionizing radiation is another cause of aplastic anemia. So ionizing radiation has a destructive effect on rapidly dividing cells of the bone marrow. As you know, because it's the factory, it's producing cells. The cells are rapidly dividing, going through all the maturation sequences, etc. So ionizing radiation will stop all that. And the predictability of the damages can be based on the radiation dosage. So if you have dosages of less than 300, then the damage to your bone marrow is reversible. Then you can get rid of the aplastic anemia. However, if your dose of radiation is 300 or greater, like 300 to 500, then now you have irreversible damage. Okay, you got complete loss of hematopoietic cells. So less than 300 or less than 300, not 300, so less than 300 is you can have reversible anemia and will lead to full recovery. Infections. Infections can have the ability to suppress bone marrow activity, resulting in aplastic anemia. You got acute infections, that means you can suppress the bone marrow for up to 2 weeks with recovery, and chronic infections can have severe results. Chronic infections can cause aplastic anemia, can cause your bone marrow to shut down. So that's hepatitis A, B, non-A, non-B, non-C, Epstein-Barr virus, cytomegalovirus, and tuberculosis. Those can cause aplastic anemia. Those are chronic infections. So if you're, okay, so just move forward. Okay, and then miscellaneous causes. Immunosuppressive therapy can trigger aplastic anemia, pregnancy, graft versus host disease. Like for example, if you need a bone marrow transplant or a liver transplant or heart transplant, you can develop graft versus host disease. Well, if you have the graft versus host disease, that can also trigger aplastic anemia. Malnutrition, your diet can cause aplastic anemia, so that's kind of scary if you eat the wrong things. Or anorexia nervosa can cause aplastic anemia. So keep an eye on your diet, eat good foods. You don't want aplastic anemia. Clinical findings. So patients present with progressive fatigue. They're always tired. They also have trouble breathing and palpitations. There also may be bleeding problems or infection. Why would they have bleeding problems? Somebody give me a reason why you would have bleeding problems.
Lack of platelets.
Correct, lack of platelets. If you don't have any platelets, one of the first things, if a patient presents with bruising or bleeding problems, they have trouble stopping their bleeding, then it's a platelet problem because they have a low platelet count. What about infection?
Lack of white blood cells.
Right. So white blood cell function is to protect you against bacteria, viruses, or whatever. If you don't have white blood cells, those are your cells that protect you. If you don't have those cells, then you're prone to infection. Okay. And then pallor secondary to anemia. All right. Thrombocytopenia. Okay. Very, very low, decreased platelet count. And that can be manifested 3 ways or several ways, but the 3 main ones are petechia, purpura, and ecchymosis. Petechia, you will be asked this. You can see that it's red. You will be asked this. Petechia is bleeding under the skin, and the size is less than 3 millimeters. Purpura is purple, and the size would be up to 1 centimeter. And then larger is ecchymosis, where you got bruising underneath the skin, and that's greater than 3 centimeters. So less than 3, 1 centimeter, and greater than 3 centimeters. Petechia, purpura, and ecchymosis. Also, too, with low platelet count, you can have mucosal bleeding or bleeding gums, also known as gingival hypertrophy. Okay, that's mucosal bleeding. And then you can have nose bleeding as well. So you have a lot of bleeding problems and bruising with low platelet count. So that's why a detailed history of blood and toxic exposure or infection is really important to help diagnose aplastic anemia. Laboratory findings, everything is decreased. PAN, meaning everything, all cell lines. So the main cell lines, like your red cell line, your WBC cell line, and also to your platelets. Those 3 main cell lines are affected. Usually for aplastic anemia, 1 cell line is affected, and then later on, all cell lines will become affected. It will be apparent. And it also starts off as normochromic normocytic. So your red cells look normal with an occasional macrocyte. And with this type of anemia, because your bone marrow is not working, your retic count is going to be normal. So the normal reference range for retic count is 0.5 to 1.5. So that looks normal. So you have a retic in the normal range, but you're suffering from aplastic anemia. And that's bad, because if you're anemic and your bone marrow is not making red cells to compensate for the red blood cell loss or lack of red cell production, then that's not good. And as I said before, the bone marrow is hypocellular, not much erythroid or myeloid material within the bone marrow. No polychromasia, you're not making red cells, no NRBCs, no immature WBCs, all reflection of a non-productive bone marrow. Okay. Testing, you can have marrow-cytogenetics to rule out myeloid disease, red cell hemoglobin F content, and DNA stability test markers for Fanconi anemia. Going to be talking about Fanconi anemia at the end of this lecture. Markers, your CD59 marker to rule out PNH, which I talked about the last lecture, paroxysmal nocturnal hemoglobinuria. So rather than a CD59 marker, you all know how to screen and confirm PNH, right? The screening sucrose hemolysis test and the confirmation, the HANS test. And then you have the direct and indirect Coombs. Basically, direct Coombs is antibody on the surface of your red blood cell, and indirect Coombs are antibodies testing that are floating around in your serum. Antibodies not on your red cell. So antibodies on your red cell is direct Coombs, and indirect Coombs are antibodies in your serum. And doing both of those tests is to rule out cytopenia due to antibodies. Okay. Serum LDH and uric acid may reflect neoplastic cell turnover. You can do a liver function test to rule out hepatitis as a chronic illness as a cause of aplastic anemia. Also, too, hepatitis A, B, and C are chronic diseases that can cause hepatitis anemia. So you want to screen for those. Viral infections like CMV, cytomegalovirus, Epstein-Barr virus, and HIV. Those viruses can cause aplastic anemia. B12 folic acid levels can also rule out megaloblastic. You can have megaloblastic pancytopenia with deficiency in those 2 vitamins, B12 and folic acid. Okay, how do we treat aplastic anemia? If you're younger than 50 years of age, then you can get a bone marrow transplant, allogeneic bone marrow stem cell transplant, and it's usually pretty successful. It's optimal if the bone marrow comes from an HLA matched sibling. Okay, you'll be pretty successful. And success diminishes if the patient had multiple transfusions in the past. So, which means that you don't want numerous external antigenic stimulations, exposures. Okay, so the less external antigen exposures you have, the better. For patients older than 50 years of age, then the stem cell transplant or the bone marrow transplant is not appropriate and will be unsuccessful. So the treatment is ATG or anti-lymphocytic globulin or anti-thymocyte. Okay, you can also give cyclosporine or cyclophosphamide, cyclosporine or cyclophosphamide or ATG. Those are for the patients 50 years of age or older. If you don't treat aplastic anemia, then it can be fatal. Okay, ATG for those patients greater than 50 years of age is given in the hospital in conjunction with blood transfusion and antibiotic therapy. Bone marrow transplantation, those are for the less than 50, is successful in children and young adults. ATG treatment leads to partial response in approximately 60% of the adults. So at least you get a response. And the long-term prognosis usually appears to be good. And that's good news for the greater than 50 group. All right, now finally, the congenital aplastic anemia. And the congenital aplastic anemia accounts for about 5% of all aplastic anemias. And the anemia is called Fanconi's anemia. And Fanconi's anemia, it's a pretty sad disease. It's a genetic disease that affects children and adults from all ethnic backgrounds. So it affects everybody, okay? And it's due to an abnormal gene and that prevents cells from fixing damaged DNA. So that you have these cells that identify damaged DNA and then it'll fix it. What happens is the gene that directs that process to take place, there's an abnormality in that. So, removing cell damaging substances called oxygen-free radicals. Right, this gene will prevent cells from fixing damaged DNA, or it'll prevent the removal of cell damaging substances called oxygen-free radicals. All right, Fanconi's anemia. These patients are short in stature. They're short. They have skeletal abnormalities. They have increased solid tumors and leukemias, aplastic anemia. They're sensitive to DNA damaging agents such as mitomycin C. And Fanconi patients normally are born with a variety of birth defects. Okay, so here's a patient with Fanconi's and it has 6 digits. So treatment in Fanconi's, first line of therapy is hematopoietic stem cell transplantation. And approximately 50 to 75% of the patients respond to androgens, which are used when transplantation is not an option. And androgens are hormones that contribute to the growth and reproduction in both men and women. Prognosis for Fanconi's anemia, many patients will develop AML, acute myelogenous leukemia, and I'll be discussing this leukemia in the leukemia section. So most of them will develop AML. Older patients are extremely likely to develop head and neck, esophageal, GI, vulval, and anal cancers. And many Fanconi patients have kidney problems, trouble with their eyes, developmental retardation, and other serious defects such as microcephaly. Clinically, hematologic abnormalities are the most serious symptoms of Fanconi's anemia. And by the age of 40, almost all of them will have developed some type of hematologic abnormality. And the symptoms appear progressively and often lead to complete bone marrow failure. So the ultimate is bone marrow failure or aplastic anemia. And that's aplastic anemia. Like I said, it's a pretty sad disease. Are there any questions? Okay. So like I said, the quiz tomorrow and the exam tomorrow, you've seen the material before, but it'll be presented in a different way. It'll make you think, especially on the exam. Read the questions, okay? Make sure they make sense. Don't jump at your first. I mean, I saw one that person jumped at. If they stuck with their first selection, they would have gotten it right. But make sure you don't just be spontaneous in saying, "Oh yeah, that's that automatic." Okay, make sure you read the questions. Read the questions, and also to know your normal values. Know your normal values. Easy points. Okay. Normal values are easy points questions. Any more questions? All right. If not, good luck on your quiz and exams tomorrow, and I'll see you in 1 week. Hopefully, I'll get these Friday morning from Xavier, and I'll correct them, and I'll send you your scores over the weekend. I wanted to ask you guys a question. Okay, so you don't see the hard copies of your actual quizzes and exams until like a week or two later. So I think that's kind of a disadvantage for you guys. How do you feel about that? Does that kind of bug you? Does that bug any of you?
It doesn't bug me, but I would like to see them, just because they help me prepare for the exam.
I think it bugs you. Don't be shy in saying that. It's okay, because what I'm planning on doing is after I give you guys your quizzes and exams, I'm going to send you the answer keys. Would that help? Don't.
That'll work fine.
Okay. All right. Because it seems like I graded your quizzes. I mean, I didn't get your last Thursday's quiz until yesterday for logistical reasons. So, and here I'm correcting your quizzes from last Thursday. You're going to be tested on it in 2 days. And I think if you had the answer key, I'm not going to give you exact verbatim quiz questions. I may by mistake, but they'll be worded in a different way. So what I'm planning on doing is after you take a quiz or an exam, I'll send you the answer key. Make sure you don't share it with future students, okay? So they'll, so that they don't ace the class next year. All right. Any other issues? Okay. If not, good luck on your exams tomorrow, and I'll see you in 1 week.
Have a good night.
Thank you.
Good night.
Thank you.
You're welcome.